Hi there. Thank you once again for joining me. I am Dr. Mahendra Carpen. I'm the head of medical services and cardiology at the Georgetown Public Hospital Corporation. The program is called Your Doctor in COVID, and we've been having conversations around the COVID-19 pandemic. If you do have any questions or comments, please feel free to send them to a WhatsApp at 620-6275 or send an email to docandcovid@gmail.com. So it's now mid-December and we have moved fully over to the Liliendal Ocean View Hospital for the management of our COVID patients. And as of the mid of December 2020, we have some numbers from the Liliendal COVID Hospital to share with you so that you can better understand what is happening at that facility. We have a total of 29 admitted patients, and we have, just to let you know, a significant number more of capacity that can accommodate patients. So we are not at full capacity, and that's a good thing. Of those 29 persons, we have 13 adults. Remember, this facility looks at not just the adults, it also looks at children, also looks at the maternity patients who are COVID positive or have all the signs and symptoms of COVID-19 and are awaiting positive results. So we have 13 adults at the facility. 9 persons are suspected. Those are ones who do not have yet a positive results, but they have all the signs and symptoms that we look for that make us suspect that these people have COVID-19 as their underlying condition. 1 person is in transition. Our transition ward, just so that we understand, is where persons with symptoms suggestive of COVID-19 are awaiting their results. In the early stages of this pandemic, and when we started doing testing, there was a massive backlog, and so therefore there was a lot of persons waiting in the transition area. Recently, we have introduced the rapid antigen testing, so we have had a lot quicker results and turnaround for our positivity or negativity time. So we know very soon if this person is positive or negative so that we can put them in the appropriate area for additional care. Therefore, it is not surprising that with that rapid availability of the answers we're looking for, that we only have 1 person there who is awaiting result. There are 6 maternity patients, those are pregnant persons, and 5 of those women are confirmed to be positive. And thankfully, we have no children in the facility at the time of preparation for this discussion this afternoon. In the ICU at Liliendal, we have 6 patients. And I'm very happy to tell you that there are no persons on a ventilator. That's no intubated person. And we have 2 who are on CPAP. CPAP is continuous positive airway pressure. That is when we use a special mask that fits over the nose and the mouth of these persons, and it helps to force oxygen into their airway so that they're always supplied with an abundant amount of oxygen. When we look at the types of ventilatory support or airway support that are available for persons, we have, of course, what we all know as the invasive mechanical ventilation, or that's the ventilator that we put patients on, where there's a tube that is introduced into the throat via the mouth, and that is hooked up to a machine, and persons are then supported in their respiration by this machine. Of course, there's non-invasive mechanical ventilation, and then there's straightforward oxygen supply that can be delivered by a mask to patients. There are several ways in which we could actually deliver oxygen to persons. And the simple one that we may all be familiar with is a nasal cannula. These are the tubes that run under the nose with two little prongs that then one in each nostril supplies oxygen. That can supply oxygen flow at 1 to almost 6 liters per minute, and the concentration of oxygen in that flow can be between 25 to 40%. The next oxygen delivery system is the face mask. That allows a flow of about 5 to 10 liters per minute, and the oxygen concentration can be between 40 to 60%. There are other devices such as what we call a face tent that again can deliver flow about 10 to 15 liters per minute and concentration of about 40%. That's what the oxygen in the air concentration is like. There are other specialized devices that allows proper exchange of inhaled and exhaled air, and of particular use within the COVID-19 pandemic is a high flow cannula that is available, which allows high concentrations of oxygen to be delivered to patients. And that can provide up to 60 liters per minute of oxygen with a concentration of between 21 to 100%. So very high concentration, very high flow. A simple mask that is used to provide oxygen to patient has very simple components to it. Most of them you will see have a piece of metal that is supposed to be easily shaped around the nose. Most of the masks are made of plastic, and there are some ports at the side of where the nose should be that allows the air that you breathe out to escape from the mask. And the mask is usually strapped with a very thin elastic strap to the back of the head. And of course, there is a tube that brings oxygen into the mask. CPAP, as we have mentioned in previous episodes, is a much more advanced way of delivering air and oxygen to these patients. It actually is connected to a bedside machine that generates the pressure, and the size of this machine varies, but most of it is about 6 to 10 inches in height and width, and it's not very heavy. But what it does, it essentially takes air from the atmosphere, processes and concentrates it, forces it through a tube into a mask, and this mask is strapped onto the patient's face at the forehead as well as below the chin, so that it forms a very tight fit, and it stays on. Persons who have what we call sleep apnea, they're not able to maintain oxygen while they're sleeping. This is one of the more common ways of treating these patients to keep oxygen going into their system. We have found that there is benefit to this mode of oxygen therapy in the COVID-19 patient, and of course we tend to utilize everything that we think can provide benefit to our patients. There are several criteria and algorithms that we use when determining how to provide extra oxygen to patients. So if you have a patient admitted to hospital, for example, and you're looking to see what this person's respiratory status is, if they have any type of indication that they're going into respiratory failure or they have respiratory failure, the first thing that we would try to do is to put on a face mask with about 50% oxygen concentration to flow into that patient. If that produces the person's oxygen saturation in their blood of more than 90%, we are very satisfied and say, okay, let's keep it at that. If, however, there is no improvement, we switch to the CPAP, which is like a helmet that goes on these patients. Again, if there is improvement, we look particularly for a ratio of oxygen in the blood versus the oxygen that is delivered. And if that reaches a certain number, then we're satisfied and we keep that as therapy. Because of the discomfort associated with CPAP, we do not keep that on all the time, but we do it in intervals, 1 to 2 hours at a time. If the person does not have any improvement with initial CPAP, then there are other things that we can do. There's something called prone ventilation, which we will talk about a little bit, but we can apply the CPAP in a prone position. That's basically turning the patient onto their tummy, and that allows more of their lung tissue to come to the surface, and gravity allows the fluid or the material in the lungs to basically occupy less space in lung tissue. These are all standard algorithms followed not just in Guyana but around the world when determining how to ventilate or provide respiratory support to these patients. The few that actually need what we call invasive mechanical ventilation, that is, you put them on a ventilator or a breathing machine, thankfully we are needing less and less of that type of support for these patients. In the early stages of, or the early phase of this pandemic, we had a lot more patients on ventilator until the world recognized that prolonged ventilation or prolonged ventilatory support actually caused more damage to these patients and produced a higher mortality or death rate among these persons. But if we do need to have ventilatory support in these patients, I just want you to understand some of the things that are involved. The patient has several tubes that go through the nose and the mouth. The one that goes through the nose usually it's called a nasogastric tube, and it goes from the nose into the stomach, and it allows us to feed the patient and drain the contents of the stomach as needed. Endotracheal tube is what usually goes through the mouth and goes from the mouth into the patient's windpipe or trachea, and that allows us to pump air and oxygen directly into the lungs. These patients actually have a need for exchange of gas, what goes in and what comes out, because you breathe in oxygen and you exhale carbon dioxide. So the ventilator must be equipped with ports that allow air to go in and allow the exhaled air to escape. The airflow to the patient passes through humidifier, which actually produces the right temperature without causing damage to the lungs. It's also moisturized so that it remains in a very friendly state to the patient's tissues. The other thing that we need to understand about these patients is when there is a need for intubation, it's a very complex process that involves several team members. And some of the common team members include the assistant. These are persons in the COVID era that has to be fully covered in their personal protective equipment from head to toe. They have gloves, they have gowns, they have shoes, etc. A respiratory therapist or a doctor will intubate this person, and then the tube is connected from the trachea onto the ventilator. But not only is the person connected to the ventilator, you also need to be connected to all kinds of monitors, including cardiac monitor, to be able to check their blood pressure, their pulse, their heart rate and rhythm, etc. So there are lots of tubes, lots of equipment, lots of machinery that are involved in ventilating a patient in the ICU. The prone ventilation is something that we have come to recognize as something that provides particular benefit for these patients in COVID-19, because as science would have it, the majority of our active lung tissue is located more towards the back. So if you turn the patient on their tummy, you bring the mass of lung tissue closer to the surface, and therefore gravity drains off fluid from the major sources of the lungs and allows more of the lung tissue to then utilize oxygen. So this is an old technique, but also works quite well in the COVID-19 patient. So I hope we would have had a better understanding, a more fruitful discussion on ventilation and oxygen delivery in these patients who are COVID-19 positive. And I want to thank you once again for joining me today. Remember, if you have questions or comments, please feel free to send a WhatsApp to 620-6275 or send an email to docandcovid@gmail.com.